Hello everyone, my name is Anila Ramaliu. I'm a family doctor and a pre-clerkship educator for the RHYME curriculum. In this podcast, part 2 of the approach to pediatric periodic health encounters, we will discuss periodic health encounters for children 6 to 17-year-old. Let's start with a clinical case scenario. You have been a clerk for a few days already in your family medicine rotation. Today, at the start of the day, you performed a well baby visit on an 18-month-old child. Later, on the same day, an 11-year-old child is scheduled for a periodic well child visit. Your family medicine preceptor suggests you see this patient too, as you obviously have an opportunity to apply your pediatric knowledge and skills today. How do you approach this visit? The objective of this podcast is to introduce you to the Great Health Record, which for short we'll call GHR throughout this podcast. Through introduction to the GHR, we will learn about evidence-based preventive care for school-age children and therefore the approach to periodic health exam for children 6 to 17 years old. By consensus, periodic health exams for children between 6 and 17 are recommended every 1 to 2 years. As we have said, periodic health exams or encounters provide an opportunity for preventive care. It is well established that office counseling works to promote several health behaviors in children. However, you should remember that although our focus in this podcast is on periodic health encounters or exams, every visit with a child or adolescent should be viewed and used as an opportunity to provide preventive care. The GHR is a tool built on the experience of the Rourke Baby Record, which we introduced in part 1 of the podcast Approach to Pediatric Periodic Health Encounters. The GHR is also endorsed by the CCFP and CPS and was last revised in 2016. That version of the GHR will be introduced in this podcast. The tool is evidence-based, and you will find, like in the RBR, that everything written in bold represents aspects of care or advice based on sound evidence. In italics, fair evidence, and everything else in non-conclusive evidence. As we have said many times, the evidence does change over time, and health professionals must keep up with it. The tool is to be considered a guide to practice. Most EMRs host the GHR, which can easily be downloaded before a visit. The GHR is built in 3 templates that guide periodic health encounter visits respectively for children 6 to 9, 10 to 13, and 14 to 17 years old. The templates contain a checklist tool. The GHR also provides 5 pages of supplementary information for professionals and patient information handouts. The GHR can be accessed using the link provided here. The checklists for each template, regardless of the child's age, are organized around these components: concerns expressed by the child or caregiver, measurements and physical examination, review of medication and immunization specific to age, nutrition, and importantly, psychosocial history and development, education, and advice. As in the case of the RBR, not all elements in each section of these templates must necessarily be covered during every visit. Clinicians can use personal discretion when selecting topics to discuss with individual pediatric patients and the timing for specific discussions. However, it is strongly recommended that children's optimal growth be assessed at each visit, and the values must be plotted using the growth charts. Blood pressure measures and visual acuity assessments should also be part of the physical examination for children of this age. Assess the sexual maturity of the adolescent. To assist with the assessment, sexual maturity rating tables are present in the GHR resource pages. Headings for other examinations are introduced to facilitate case finding, but breast examination and testicular examination are to be excluded. Also, the evidence does not support routine and universal laboratory investigations of children of this age. Specific laboratory screens are done in special circumstances and are discussed later in this podcast. It is important to note that the focus of discussion about psychosocial history and development during pediatric periodic health encounters for this age group changes with the child's age and level of maturity, the child's life experiences, and anticipated changes. For younger children, the inquiry should focus on family structures and dynamics, including discipline, school performance, extracurricular activities, peer relationships, and specifically bullying. For older children, discuss the evolving nature of the adolescent's relationship with peers and family, and inquire about school, work, and social groups. Confidentiality is a cornerstone of any therapeutic relationship with youth. You must start the interview with teens by clarifying the limits of confidentiality, or else you risk getting incorrect or incomplete information. The common law in Canada states that a minor can give informed consent to therapeutic medical treatment, provided they understand the information regarding the proposed treatment and can appreciate the possible consequences. Further information on this is provided in the resources accompanying this podcast. Thus, part of or all the visit, especially during history taking, can be conducted without caregivers present. However, in most cases, it is essential to speak with the caregivers to discuss their concerns and define any issues they may have about parenting an adolescent. Some of the issues to address during psychosocial history and development are the following. Unfortunately, living in poverty is a reality for a lot of children. It is well established that growing up in poverty is associated with morbidity and mortality in childhood and later in life. Assessing children for such needs and being aware of supportive resources targeted to them is an essential skill of primary care providers. When discussing the use of substances and addiction, consider expanding inquiry to include problematic internet use, excessive screen time, video gaming, cell phone behavior, as well as common substance-related habits that cause harm, such as smoking, specifically e-cigarette use, alcohol and drug use, including legal drugs, as well as opioids and stimulants such as caffeinated energy drinks. Note that some of these issues can start as early as 9 to 10 years old. The CRAFT screening interview helps solicit this information and can be found on the GHR resource pages. Some of these behaviors or exposures are often associated with mental health issues like depression, anxiety, self-esteem, self-harm, and suicide. Screening for major depressive disorders in adolescents is recommended provided that systems for diagnosis, treatment, and follow-up are in place. As sexual maturity and body changes of the child take place during these years, sexual health and relationships should also be addressed. The inquiry should include physical and psychological factors that affect sexual development, sexual function, and reproductive health. These topics must be addressed with sensitivity and may consist of discussions about sexual orientation, consent, dating safety and abusive relationships, sexting, contraception, including emergency contraception and STI prevention. It is important to ask children of this age about the foods they eat, body image and self-esteem, desire to change weight, body shape and exercise, vitamins or supplements they take, sedentary behavior or lack of physical activity, and sleep issues. All the above have a significant impact on their growing bodies, daytime functioning, school and work performance, and quality of life at their age and for the years to come. Dental care should be discussed. Flossing and brushing using fluoride-containing toothpaste should be advised. In areas where fluoride is not part of drinking water, fluoride supplementation should be addressed. Injury prevention and safety, including but not limited to wearing a helmet when cycling, skiing, or skating, wearing a seatbelt while driving, safe driving practices, sun protection, avoidance of tanning salons, firearm safety, workplace safety, and concussion prevention are all aspects of care and advice to be addressed during periodic health exams of children in this age group. Healthcare providers should also remain vigilant for signs and symptoms of abuse, maltreatment, and neglect discussed in detail in another podcast. A simplified assessment and interview of an adolescent can be done using HEADS, a well-regarded and known mnemonic that can help structure the assessment of an adolescent patient, encompassing things we already discussed. The assessment should start with simple and easy questions about life to allow for a rapport to be built before delving into more personal questions. As we mentioned earlier, the GHR contains supplementary pages that serve as resources for health professionals to use when applying the GHR templates. This slide shows one of these pages, and specifically page 4 of the GHR resource pages. You can see that it provides guidance on what questions you may use when applying the HEADS mnemonic, which we just introduced, and how to sensitively address some of the sexual health issues relevant for this age group. This page also provides a link to guidelines about what to screen and not to screen regarding teen sexual health. A description of all 5 professional resource pages included within the GHR is provided here. Make sure to familiarize yourself with the information contained in these pages. Reading through these pages will be the basis for building your professional capacity to appropriately conduct a periodic health encounter for a child 6 to 17 years old. Begin to familiarize yourself with this information. A PDF copy of these pages accompanies this podcast and has been provided as required reading for this topic. We will stop here to introduce a not all-inclusive summary of screening recommendations provided for this age group in the GHR. Consider all the following. Please pay attention to do's and don'ts. Screen for major depressive disorder children 12 to 17 years old when risk factors are present. Know the risk factors. Screen for chlamydia and gonorrhea, all sexually active teens at risk. Screen for HIV, all sexually active teens greater than 15 years of age. Teen less than 15 years old should be screened for STIs when risk factors are present. Cervical cancer screening or HPV testing is not recommended at this age. Refer to the guidelines we have introduced elsewhere as to what age the cervical cancer screening starts. Do not screen for idiopathic scoliosis, asymptomatic teens. Confirm rubella immunity in sexually active teens, but laboratory screen is not always necessary when history of infections and immunization is known. Screen with ferritin levels if the child is at high risk for iron deficiency. Know the risk factors for iron deficiency. Screen with lipid and plasma glucose all children greater than 10 years old if their weight is above norm. May consider screening with lipid and plasma glucose also children with familial dyslipidemia and strong family history of diabetes. As with everything else about screening, these recommendations may change and you must stay up to date. More information about evidence-based guidelines about screening at this age are provided in the professional resource pages of the GHR and the links associated with them. Here are some of the points we have covered and that you can take away from this podcast. Take a minute to review. Let us now return to the clinical case scenario introduced at the beginning of this podcast. Try to answer the questions listed on this slide. Once you have done so, create hypothetical case scenarios in your mind as to what you might do differently if the child was greater than 11 years old, but younger than 15, or older than 15 and presented with several risk factors. How would you handle these cases? What will you do differently for each one of them? And with that, I would like to say thank you for listening.